Thank you very much, Jack. And it's a great honor to be here, and I appreciate the invitation. Apologies if just a couple of these slides are familiar to the folks who were in the melanoma breakout. So you can go to the head of the class, as I said before. So just to review with you that although immunotherapy has become very popular lately with science, sort of naming this field the breakthrough of 2013, investigators, specifically at my institution, Memorial Sloan Kettering, and others have been interested in this for over 120 years. Just a nod to the history of William Coley there on the left side of the slide, who really made the pivotal observation in 1890s that patients who got infections after cancer surgery tended to live longer than those who didn't, with the hypothesis being that those infections were in fact mobilizing what was at the time not known to be called the immune system, but what was the immune system, as a way to keep the cancer at bay. This moved forward with the development of IL-2, which you've heard about earlier today, and the type of durable response to IL-2 seen here for melanoma, but also representative for kidney cancer. This is data that Dr. Atkins generated with that very characteristic horizontal nature of the survival curve after about 2 to 3 years, indicating long-lived response in terms of durable immune memory. I'm not going to once again review the fact that CTLA-4 is a critical inhibitory molecule on T cells, which prevents them from getting hyperactivated, but will remind you that the best way to think about CTLA-4 is that it is a brake, that if your T cell receptor is the ignition key, and if CD28, an activation marker on T cells, is the gas pedal, then CTLA-4 is the brake that keeps T cells from becoming overly activated. And if one has a speeding car with your foot on the gas and no brake, then that is not going to end well. And that's in fact what happens if you breed a mouse to lack CTLA-4. That mouse dies actually at 3 weeks of age of fulminant T cell infiltration of every organ in the body. So we know that CTLA-4 is very important as a target for immune regulation. We also know that if you're going to block it, that should be done temporarily and not permanently. And so that is why Dr. Allison really envisioned the idea of blocking CTLA-4 as a way to enhance tumor immunity. And I thought it would be instructive as we talk about endpoints for immunotherapy trials to actually review this primary data from Dr. Allison's paper, which was written by a postdoc of his at the time, Dana Leach, in 1996. So this is a very simple experiment. A bunch of immune-competent mice were engrafted with colon cancer tumors, and then they were treated with a mouse version of Ipilimumab, an anti-CTLA-4 antibody, or they were given an antibody to the activation marker or the gas pedal, which is the CD28 molecule. And what you can see is that if you block CTLA-4, you get durable control of tumor growth. If you block the gas pedal, it actually causes the tumor to grow a little bit more quickly. But what I've circled here at about day 15 is that all of these tumors enlarged before they eventually regressed. So it's very important to keep that in mind as we interpret the clinical results of immunotherapy, that we may not see tumors regress immediately. They may grow while the immune system becomes activated and learns to recognize the targets that it needs to learn to recognize in order to enact a regression. And also, the things may in fact appear larger, not necessarily because there are more tumor cells, but perhaps because there are more immune cells in those tumors that make them appear larger even though they don't have as many actual tumor cells. So some patients will respond very quickly to Ipilimumab. This is a melanoma patient treated at the National Cancer Institute with dozens of lung metastases that regressed and even a brain metastasis that regressed. We're all now very familiar with the side effects of CTLA-4 blockade, so in the interest of time, we'll skip through that. But this is actually one of the most rapid responses I've ever seen to anti-CTLA-4. This is a patient with metastatic melanoma with all these little lumps and bumps on the surface of the left leg, which by the time of the third dose of antibody, all of that disease had regressed. Which was quite impressive. And you can also see that there are these darkened areas on the thigh where the tumors were. And we were very interested to see if there was additional melanoma there that had not yet gone away. But our pathologist actually said that no, there was no melanoma there. Those were just white blood cells called macrophages and also lymphocytes or T cells intermixed with the debris of the dead melanoma cells, the melanin pigment. That is highly, highly insoluble and difficult for the body to digest, is left sort of like a tattoo of where the melanoma cells were. And then if we look a little bit more carefully, we can see that there are actually these CD8 positive T cells, which were spoken about earlier, which are the ones that were very interested in getting into the tumor, had infiltrated the tumor as these pink dots. And so this was a very striking example of within just a few weeks, where tumors were before was now just debris of dead tumors and a very nice population of the very immune cells that we had hoped would be there. But not every patient responds like that, and this is what we need to keep in mind. This is another patient that I treated around the same time with Ipilimumab. And this is a CAT scan. This big gray organ over here is the liver. And this is a patient who had metastatic melanoma to the liver and the kidney. He received 4 doses of Ipilimumab, and after he came back for his 4th dose, I looked at these images, and it looks like there are more of these kind of darker gray spots in the liver, which represent metastases. And so this really is a very good example of progression of disease by standard imaging. It looks like there are more metastases. The ones that were there before are larger. And so I was preparing to give unfortunate news to the patient when, in his very New York way, he stopped me and told me that he felt better. And that for the past 2 weeks he had night sweats and fevers and liver pain that had all gone away. And so we really thought that perhaps the way that we think about the timing of responses to immunotherapy was different than chemotherapy or targeted therapy or radiation therapy, which are all modalities that target the proliferation or the growth of tumor cells. And if you stop that proliferation or growth, then you would just expect things to get smaller. But here, none of these medicines are really doing anything directly to the tumor cell that we know of. Rather, it's causing the immune system to become activated, and then at some unknown point in time, the immune system will cause the tumors to get smaller. And as I mentioned before, they may actually look bigger in the near term because of the fact that immune cells may cause the tumors to swell. So without any better therapies to offer this patient, and with the fact that, importantly, he said he felt better, we actually said, well, why don't you just wait? And he came back in 2 months and had another set of scans, and lo and behold, most of that disease went away with no additional therapy. And it continued to go away to the point that essentially he had a complete response with no additional treatment other than a few more doses of Ipilimumab. So we began as a community of investigators to think about how we could categorize these responses. 2 of them were conventional. You know, the tumors that were there at the beginning went away or got smaller over time. But 2 of them were novel and defied the usual rules that we use to judge the activity of anti-cancer treatments. In some patients, like the one I showed you, responses occurred, but after things looked like they got worse. Or the tumors that were present at diagnosis actually got smaller, but new tumors arose. And by the way that scans are usually interpreted in clinical trials done, the appearance of new tumors is really grounds for declaring drug failure. And so we thought that that was a challenge that we needed to think about overcoming. And so you can't see these numbers. I apologize for that. This is the primary data that was looked at by ourselves and our colleagues from Bristol Myers Squibb from 227 patients treated with Ipilimumab in the phase 2 program. And so of that 227 patients, 123 had progression of disease on their scans done after the 4 doses of Ipilimumab. Now, that's more than half, and however, about half of those patients, 57 of 123, were followed beyond progression with no additional treatment. They just had scans, just like that patient that I showed you with the liver metastases. And of that 57 patients, 14 of them eventually responded with no additional treatment. So depending upon whether you do 14 out of 57 or 14 out of 123, you've got somewhere between a 10 and 25% likelihood of actually having a good result, even when the first set of scans suggests otherwise. And that is the rationale for why oncologists now will sometimes suggest that patients who have scans that are looking worse but feel okay don't take any action, but rather just wait a little bit longer, that there is an actual number between 10 and 25% of people will get better with no additional intervention. And this was a very important number to provide doctors and patients with. And so based on that, we actually came up with some different rules to judge the activity by. They've been called the immune-related response criteria. And they basically say, take the normal rules that you read scans by, measure the individual tumors, but if you have a patient who's asymptomatically progressing on the scan, repeat the scan. And if you've got a patient where the tumors that were present at the beginning are getting better, but they've got a few new tumors, rather than just calling it a day because of the appearance of new tumors, add everything together. And if the total is still better, even in the presence of the new tumors, that's okay. And so with those two caveats, we created this group of patients shown in the dark blue line here. These were folks who, by standard imaging criteria, represent progression of disease or worsening. And this is the group of patients who had worsening disease by any imaging criteria. These are the patients who improved on schedule at week 12. And so you can see that the overall outcomes for these patients, even at 2.5 years, are the same. So it doesn't matter how quickly the scans improved. It just matters what rules you use to read those scans by. And as you know, this has translated into about 20 to 21% of patients with Ipilimumab having long-term survival, 3 years or longer, with that same very characteristic flattening of that survival curve with in this case, about 21% greater than 3 years. Now, this is also true for PD-1 blockade, which you've heard a lot about today. So just to show you some examples, in these curves, where each line shows you the tumor growth or the tumor regression of individual patients, these are melanoma patients treated with Nivolumab, an anti-PD-1 antibody. You could see that there's about a third of patients whose tumors are getting smaller over time. But if you look over here, these are patients who had these atypical responses, here with Nivolumab as well. Here's a patient who got worse before he or she got better. And here are patients who had new tumors appearing, even in the context of someone who eventually went on to have a complete response. So this idea of the immune-related or atypical responses is not something unique to Ipilimumab, and we've been observing this in patients treated with Nivolumab, with Pembrolizumab, with 3280A, with Medi4736, with all of the PD-1 and PD-L1 blocking drugs. So I'm going to stop there, leave a little time for questions. This is a diagram that I showed earlier showing all the different points in which the immune system and tumor cells can interact with each other, and all the points at which we can actually cut the brakes or step on the gas a little bit more to help the immune system get the upper hand. Thanks so much for your attention. This is my research group and our very, very valued funding organizations below there, and the clinical trial team who helps us take such good care of our patients. Thanks very much for your attention.